this next patient is a very challenging, hopefully not too disconcerting, in that she's 45 and has had significant weight loss and abdominal pain. And by her MRIs done outside, there's a suggestion that she might have something in her pancreas. She's got a strong family history of pancreatic. When I say strong, her mother passed away from liver and pancreatic cancer that had metastasized to the liver. And she's had significant back pain. She's had chronic back pain for many years in her life. However, in the last several months, the character of her pain has changed to where it's more in the left upper side, and she's unable to eat. And she has an elevated, markedly elevated CA19-9, which is a tumor marker. The sensitivities and specificities aren't great for pancreatic cancer. However, when it's so highly elevated, such as in her of about 600, we worry that in fact there might be a cancer in the pancreas. Imaging such as MRI and CT scan is very good for picking up tumors. However, endoscopic ultrasound is the most sensitive modality for detecting pancreatic masses, especially when they're less than 2 centimeters. So right now we're looking, because I don't know what we're going to find. If we knew that she had a mass in her pancreas, I'd probably go straight down with our linear scope just to perform a fine needle aspiration. However, since we don't know that, I'm going to go in with the radial just to get an overall look. Many endosonographers would argue that sort of rationale and say that you should go in with a linear no matter what, because the imaging is better. However, many would say that a radial gives you a better overall look, and therefore that's why we're going to go in with the radial scope. So we're going to go ahead and intubate the scope. We always look for the cords, and there they are. And this scope is such that you don't want to push too hard if it's not opening, just because the flexion is... So we're in the stomach right now, and I try to save the EUS unless I'm really using it, and and already I'm seeing things that concern me somewhat. There is indeed a mass that I've already identified, and just very quickly, I'm very concerned that the portal vein is in fact involved, and I will point these out in a second. So in hindsight, perhaps I could have gone straight in with the linear, and you could see within a matter of 20 to 30 seconds we're able to detect a mass. And I'm shocked that an MRI, although they thought that there was some suspicion, could not detect one. What I'm measuring right here is the bile duct, and when patients get jaundice or yellow, although it's troubling to the patients, I tell them that that's perhaps a blessing in disguise, because then they seek medical attention when they turn yellow. However, when patients don't get jaundice, then they don't seek medical attention, and then unfortunately a pancreatic mass might be too late. And what I'm measuring here is the bile duct, and it is not dilated at all. It's 3.5 millimeters, normal being up to 6, and right beneath there is the pancreatic duct, and the pancreatic duct is not dilated either. So this is an unusual condition, in that this is 3 millimeters there, in that we've got a presumed pancreatic mass, or highly suspicious pancreatic mass right there. And I will magnify this. This area right from approximately here up to here, and so I think you can appreciate the margins. It's not completely well circumscribed. I'm measuring this at about 3.3 by 2 centimeters. This mass does not appear to involve the She also has scattered adenopathy, or lymph nodes, and the lymph nodes are right here would be a lymph node. And the way we know it's a lymph node is these tend to come in and out of the screen rather than elongation, which you would see with the blood vessels. So, and before I complete this and switch over to our biopsy scope, I'm just going to go on downstream to get into the to visualize the uncinate pancreas, and we get to the transverse duodenum here. What's nice in terms of actually logistically being able to do the case is the patient, if you'll note, is very comfortable and well sedated. And in the past, we would often have huge challenge in patients moving, and we use droperidol, which has become sort of a black box, and we don't have access to droperidol because of elongation of the QT interval. So we were really left with just using Demerol and Versed, and we would be giving whopping doses of both of those medications, and that's the way EUS has done it a lot of places because they don't have the luxury of, say, anesthesia providing MAC or monitored anesthesia care with propofol, and we do have that luxury. So all of our cases are done with MAC anesthesia. I'm just measuring this lymph node that is present close to the IVC, so this would be a portocaval lymph node of approximately 1.2 centimeters. And I'm coming back from the uncinate view again, and here's a mass. I will demarcate this a little in greater detail. Perhaps my scope has flipped back. We see a little bit of food in the stomach, and it's not to say that the patients ate, but often in the setting of pancreatic cancer with involvement of the celiac plexus and the ganglia, patients have marked dysmotility so that their food does not go through the stomach very easily, and so that's a challenge because the patients not only have pain, they're on narcotics which slows the motility, but then the tumor often will invade the neural plexus, and so they have dysmotility there. What I'm seeing here in the body of the pancreas, along with some nodes, are changes that are suggestive of chronic pancreatitis. So I don't know, I didn't get a good history of alcohol use in her. Perhaps she ingested alcohol before, and the mass that we're seeing now in the head might be in the setting of chronic pancreatitis. And there's a beautiful image of the bile duct going from here all the way down to the ampulla, and this is the pancreatic duct. What might be a challenge is that this mass or suspected tumor, you can see we might have to go through the bile duct, and so that can be somewhat problematic. And we'll just have to see exactly how the linear scope lines up in terms of the path of the needle. And there's the mass right here. Here's a better depiction. I think it's delineated somewhat better right here, and it is consistent with how we measured it before. So now I will probably go ahead and this is the portal vein right there, so it appears that the portal vein is completely obliterated. I'm going to go ahead and pull this scope out and then go in with our biopsy or the linear scope. When I come out, I do like to look at the mediastinum. There's the body of the pancreas with marked changes of chronic pancreatitis and ectatic pancreatic duct. There's some scattered lymph nodes again right there. Those are small lymph nodes. I've just magnified. We also like to look at the lymph nodes going in and out of the plane, and we need to evaluate for celiac adenopathy. We know we're at the GE junction because of these two structures. Here's the aorta, and here's the inferior vena cava, this triangular structure right there. This would correspond to the gastroesophageal junction. She has a hiatal hernia, which we can visualize by EUS, reflected by all these gastric folds. And I'm going in, and she does have a calcified node which appears to be a celiac lymph node. So if all these are bad signs, unfortunately, now I'm going to check the mediastinum. We have detected at least 4 to 5 patients where their pancreatic cancer has metastasized to the mediastinum. Now there are some mediastinal lymph nodes right there. Just a quick cursory look, they appear to be benign just by the appearance, but one never really knows unless you biopsy. But this is a lymph node in the middle of your chest, which would correspond to the carinal space, measuring approximately 1 centimeter. The structure just inferior to that node is the SVC. The aorta is at 3 o'clock. I'm sorry, the azygous vein, I apologize, at 9 o'clock. And now we're pulling out. Switch scopes here. So now that we've established that there is a mass, we will go ahead and pass the biopsy scope or the linear scope that has Doppler capabilities. Again, intubating, one must use caution to not perforate the upper esophagus, especially in the elderly, which so many of our patients for cancer staging are older. So these are, I'm now into the body of her pancreas, and we get to the, here's her aorta. This is her adrenal gland right here. Call this as a Texas Longhorn shape or a seagull. This is the left adrenal gland. This is the crus of the diaphragm, and this is the aorta. And you can see the left kidney. Mary, if you just put some alcohol swab on this thing. That's the left kidney right there.
Go back and measure the bowel duct and say 3 millimeters instead of 3 centimeters. So they can edit.
Okay. So she does have some evidence of adenopathy right here, and we may or may not decide to do a fine needle aspiration of that. She's got actually very large nodes, and now that I am studying this, gosh, it would be really nice if this was a lymphoma because of these pronounced lymph nodes. So it would be a far better prognosis for her if this ended up being a lymphoma. The only thing clinically that argues against a lymphoma is that CA19-9 level being up so high, which would be more consistent with an adenocarcinoma and not a lymphoma. So I'm back in the head area. This is, most of the FNAs are performed with the scope in the duodenal bulb, and that's where I'm at right now. And here is the mass, which is evident right here. I inadvertently hit a wrong button, so I'll remeasure here. For our scopes, we find it best if the sheath length is adjusted to approximately 1. It may vary depending on your endoscope, but somewhere in the range of 0.5 to perhaps 3 on the sheath. The Echo needle has a nickel-plated brass lure lock that offers a solid connection to the biopsy port of the echoendoscope. This feature offers more stability even with multiple passes. Now, Cook has come out with several different needles, the Echo 322 and the Echo 122. I personally prefer the Echo 322 over the 122 because it offers a coiled sheath And this enhances flexibility, especially in lesions that might be lesions that require torque on the scope, and because of that torque, you would really favor having increased flexibility with the spring tip, and that's the instances where I use that. I've got a fairly nice position right here. I do see arterial structures anterior to the mass. I'm just magnifying here. We can Doppler prior to performing the biopsy, and the structure right above the mass, I presume, is the gastric duodenal artery. Here's a lymph node right there, and the mass again, and that's the portal vein with the flow. So one can appreciate that this mass is completely compressing against or on the portal vein. It's a lymph node and the mass again. There's no harm in going after the lymph node. We'd like to biopsy the mass first if possible. Have that gastroduodenal artery right over. Here's another lymph node. And these look quite ominous. They're large, fairly round and well demarcated, all signs of possible malignant invasion. Let's just go for it. Okay. That's good. So you can appreciate there's flow right above the mass, and we will like to avoid that if possible. I'm just going to check to see which plane. So my needle's coming right where that artery is, so I'll have to. That's not bad right there. Okay. You're going to be able to. We could probably maybe do it without suction. I'm going to perform the first pass without. You can do it? We'll still do it without suction though. Just push in just a little bit. So Mary, our nurse, is actually pushing the scope gently into the patient. And you can see the needle, and I went right in. It's fairly soft, which is somewhat uncharacteristic for pancreatic masses. There's a chance that all this could be lymph node material. Go ahead. So the needle's in, and now she's inserting the suction that's been. I'm just going to magnify a little bit, and you can see the needle going in and out of the patient here. That's the portal vein sitting right behind us, and so we'll avoid that. And probably do about 10 to and fro motions in order to get a sample. And we also look in our syringe to make sure there's no blood that's returned. It's not a major deal if we do see blood. We just stop and pull out with that pass. Turn the suction off, and the needle's back. So that constitutes one FNA pass. And we'll just move over and process the sample and put it on a slide, and then our cytopathology colleagues will stain it right outside the room. Just go. Okay, so here's what a specimen would look like with I keep a slide in the back just as a guard so we don't lose sample. And then this is for us. That's fine. You can just push through. A cell block material will be made, and I'll just gently smear the two slides like we do in microbiology from undergraduate days. One will go in an alcohol, and this is very similar to a pap smear. And there's material there, and we'll give this to our tech. Thank you. And then we'll do this over again, and she'll let me know what kind of specimen was obtained. The mass was a little bit technically challenging to get to because of that artery. So if we're unsuccessful again, I might sample the lymph node. In between, I'll tend to flush the biopsy port just to make sure there's no debris or junk. Or if we were to sample the node, I would change the needle because to avoid cross-contamination, so we would know that the node indeed had tumor and that it wouldn't be a false positive from a residual cancer cells from the prior biopsy. But we're able to torque and change the position so that we can get a better view. Okay. So you can note here, this is a slightly altered view, and we will use suction on this pass again. And I can see that, so my needle's coming out more at a 45-degree angle. I'd like it, or more, that's good. What's that? Okay, so I'm in the lesion. Go ahead. I'll show you the tip in just a second. One should always secure this with the right hand in, so that, go ahead. And so gentle manipulation with the shoulder or left-right should bring the tip into view. And there's the tip. You can see the tip going in and out, and I think it's because of the torque that I have on the scope with this mass that's made it a little bit harder to see it. Suction off, and we'll see what we get. So this would constitute pass 2. I'll probably do 3 passes into the mass if we're unable to get a tissue diagnosis, and then we'll change over and then biopsy the node if we need to. Typically we do about 3 to 5 passes, and that was the 3rd pass, and I'm convinced that was the 2nd pass, and I'm convinced there's a mass right there, and should be the same blood flow pattern that we saw, and here's this large lymph node. Boy, this is a very circuitous or tortuous artery right there, the gastroduodenal. It's coming traipsing over the mass. So I'm confident that we'll get a diagnosis. If it's not in the mass, then probably the node. And some folks would argue, why not just go for the node straight off? And that's a reasonable argument. It's just kind of, at least in my mind, I'd like to know if there's cancer in the mass first and then surrounding areas. Now, if I went straight for that mediastinal node, that would have been a reasonable thing to do, because then you would know there's metastatic disease, and I don't think anyone would argue that it's probably coming from this mass. I'll do one more pass, and into the mass, and if not, we'll switch and do the node. So our cytotech has come and told us that the 2nd pass was diagnostic for malignant cells or cancer. That should be good. I know that we've got cell block material, so that should be even added confidence in case they needed to do special stains. In my mind, this is where the thought process of EUS comes in. We can biopsy many things and get a diagnosis. Is it going to matter if that node is positive right around the tumor, or mass? Probably not. So I probably don't need to do any more passes there. What we hate to happen is for on preliminary to be something that suggests a cancer and then the final to not be read as such, because that really is that's unsatisfactory for chemotherapy or radiation. They need biopsy proven stuff. So what I'm going to do is just temporarily step away, look at it myself, and see if I feel that there's going to be any hesitation at all in making this diagnosis. If I feel comfortable that it really is, and I trust our cytotechs very much, but I would hate for the patient to have to come back for another procedure. And I'll also look at the mediastinal area and try to ascertain whether this is something that's going to be of clinical significance. And these nodes, there is a lymph node right there. I'm not, it could, or it's just not, there's a little central rim of calcification in the center of it. So it might be a benign granulomatous node right there, but that is indeed something that we may consider biopsying right there. So in the process of coming back to evaluate that abnormal lymph node, I ran across this hypoechoic round structure in the liver. I'll try to mark this for you. It measures right here. So this lesion measures right at about 1 centimeter. And you say, well, how do you know this represents a metastatic spread versus normal liver? And it's one of these things that you don't see something that looks like that. A tumor spread, it can be hypo or hyper, and in fact, I'm seeing something that's closer to the edge for me to biopsy. Perhaps you can appreciate it as well. It's right here. So this is the first thing that hit my eye, and then this area is right near it, and this should be easier to biopsy, and it's in the left lobe of the liver and the lateral edge. And a good endosonographer should look in every case that he or she does in the setting of pancreatic or esophageal. And there's several nice case series, the largest published by Dr. DeWitt, John DeWitt out of Indiana, where it was a multi-center, and they looked at their experience in pancreatic cancers of liver lesions that had been biopsied. And I'm seeing several, so I'm really becoming convinced that these really represent metastatic foci. Clinically, the implications of this would be that she's got metastatic pancreatic cancer, and that would obviate the need for any surgery, and she would be in a palliative mode. This is a 25 gauge needle. I personally use the 25 gauge needle if I'm somewhat concerned about increased bleeding or clots, perhaps very vascular lesions such as a cyst, and so a smaller needle potentially offers you the same specimen but with less bleeding. That's why I use the 25 gauge in the liver, because it is a very vascular organ, and that might prevent further bleeding as well. The other thing that I've found is that despite using a smaller 25 gauge needle, I've never really seen any sacrifice, or I've never seen any decrease in visibility. In fact, the visibility is just equal or as good as the 22 gauge needle, and when you look at the specimen, the quality and the amount of the specimen that one obtains is pretty much equal to the 22 gauge needle, with the caveat being that perhaps there's less bleeding, and that's a good thing. Okay, so we'll do this without suction right there. Mary's holding a little bit of torque toward, perfect, right there. It's a little counterclockwise torque. Ideally, you should Doppler to make sure that there's, whoop, we've rolled off there. Right there, okay, so that looks fine. Our Doppler angle would be fine. You see it, Mary?
Mm-hmm.
The needle's coming just a little bit above, so I've used my elevator just to push me down just a tad. It's still coming a little bit more superior, and now I've pushed my... Okay, so I'm right in there, and you can see the needle tip. The whole issue of whether suction or no suction should be used is quite interesting. Dr. Wallace first published a nice series when he was at Charleston in the setting of lymph nodes. I have not published our series, but typically the first thing I'll do is without suction because there's less blood clots and debris. If it looks like we're getting material without suction, then that's better. So it's really a feel. Now in the liver, which is a vascular organ, I think I just feel comfortable without suction as the first go. There's a large celiac node here. And then the time factor, doing this with conscious sedation would be challenging. And what I'm measuring here is she does have a celiac lymph node. So all these are bad prognostic factors. All right, so I'll go ahead and load my needle again. We may try suction this time. I'm just loading the sheath. It fits nicely. If for some reason the sheath and the needle system isn't screwing on easily, then I would not force the issue. There's several techniques that one can use to make sure that the sheath and the needle do go in correctly. Where it becomes somewhat problematic is beyond the duodenal bulb. Okay, so on the first stick it appears that we were successful in getting tumor cells from the liver, which is a very powerful thing. Unfortunately bad for the patient, but very powerful from a clinical standpoint. So today, in a patient that had suspected pancreatic cancer on an MRI but no definitive diagnosis for the lack of a mass, in approximately half an hour to 45 minutes, we've biopsied a pancreatic mass, measured the dimensions, shown that it's unresectable because there's portal vein obliteration as well as probable SMA involvement, and then we've identified metastatic celiac lymph nodes in the setting of pancreatic cancer, or presumed metastatic, and at least 3 or 4 liver lesions, and we biopsied the pancreatic mass and the liver lesion with 2 different needles, some using no suction in the liver lesion because of the vascular concern, and suction on the mass. It took us 2 biopsy or 2 passes, FNA passes, to get a diagnosis in the pancreas, and 1. So a total of 3 passes, Mary? Is that correct? Where we were able to make all this. So quite powerful, and now there's really no need to do this further, and I'm going to go ahead and pull the scope out.